الآخرة هم يوقنون أولئك على هدى من ربهم وأولئك هم المفلحون. بسم الله الرحمن الرحيم إنا أعطيناك الكوثر فصل لربك وانحر إن شانئك هو الأبتر. صدق الله العلي العظيم.
والآن إلى من ضحوا في سبيل الوطن نقف إجلالا وإكراما لهم لقراءة سورة الفاتحة على أرواح الشهداء من قواتنا الأمنية والحشد الشعبي. جميعا والآن نستمع إلى النشيد الوطني.
والطيبات المحترمين الحضور الكرام، السلام عليكم ورحمة الله وبركاته. تيمنا بميلاد خاتم الأنبياء والمرسلين وأشرف الخلق أجمعين نبينا محمد صلى الله عليه وآله، نحتفل هذا اليوم بمناسبة مرور 5 سنوات على تأسيس مستشفى المواساة الأهلي. هذا الصرح الطبي المتميز وإدارته التي قدمت خدمة طبية وعلاجية تليق ببصرتنا الحبيبة، فهي تضم أطباء أكفاء كرسوا أنفسهم لخدمة المرضى والسهر على راحتهم وتقديم كل ما هو حديث من الأجهزة والمعدات الطبية. تعتبر مستشفى المواساة أحدى نوافذ دائرة صحة البصرة، فهي ترتبط بعلاقة وثيقة الصلة بمؤسسات وزارة الصحة، وتعتبر الساعد الأيمن لها، وتقدم الإسناد والدعم اللوجستي للمستشفيات الحكومية الأخرى. إن التواصل والتفاعل بين إدارة المستشفى والأطباء بكل اختصاصاتهم ومنتسبيها من جهة، والمستفيدين من هذه الخدمات من جهة أخرى من مرضى ومراجعين ومتدربين وباحثين، هو محور رسالتنا ورؤيتنا لتحقيق الهدف الأساسي في خدمة طبية متكاملة. إن من أحدث التطورات التي أضيفت إلى المستشفى خلال هذا العام ممكن تلخيصها بالآتي: استحداث جهاز إيكو ثلاثي الأبعاد وبمواصفات عالية الجودة مع جهاز هولتر وفحص الإجهاد ووظائف الرئة. استحداث جهاز رنين مغناطيسي من شركة فيليبس وبمواصفات عالية الجودة. استحداث أيضا سونار رباعي وثلاثي الأبعاد، وكذلك نواظير عمليات ثلاثية الأبعاد لصالات العمليات. نشير إلى دعم وإسناد كل من الحكومة المحلية ودائرة صحة البصرة بما قدمته من إرشادات وتوعية ودعم غير محدود بالمعلومات والأوامر الإدارية والفنية والدورات من أجل تحقيق هذا الهدف السامي، هو إنجاز خدمة طبية متكاملة. وأخيرا نسأل الله سبحانه وتعالى أن يوفق القائمين على هذا الصرح الطبي لما فيه عزة ورفعة ونماء لهذه المدينة، إنه سميع مجيب.
The pancreatic pseudocyst was described 2 centuries ago by Morgan et al. Who established its formation and the anatomic characteristics for the first time. By definition, pancreatic pseudocyst is an encapsulated collection of fluid with a well-defined inflammatory wall, minimal or no necrosis, which often requires for maturation for about 4 weeks from the onset of pancreatic episode. Pancreatic pseudocysts are the most common complication of acute and chronic pancreatitis. The incidence is about 14.6% in acute pancreatitis and 41.8% in acute on chronic pancreatitis. Staging various strategies have been used to predict the severity and outcome of acute pancreatitis, including the Ranson-Non criteria and the acute physiological and chronic health evaluation. It is called the Apache 1 and then the Apache 2, and the Glasgow classification and the Emery scoring system. Each has advantage and disadvantage, and none is currently recognized as the criterion of standard. For the research purposes, the Atlanta classification of acute pancreatitis has been used to differentiate between severe and mild case of acute pancreatitis. Acute pancreatitis has 2 phases. The early and late had 3 severities. Thin, it is less than 1 centimeter in thickness, and should be adherent to the organ aimed to be drained from, like the duodenum. There is contraindication to other procedures like previous abdominal surgery or comorbidities which complicate other procedures. The contraindication to endoscopic drainage is bleeding disorders, gastric varices, CT finding of thick debris, and multilocular cysts. Transenteric usually is a cystogastrostomy or cystoduodenostomy or cystojejunostomy. The transpapillary approach. In 40 to 70% of the cysts, they communicate with the pancreatic duct. So ERCP, sphincterotomy, and the balloon dilatation, then stenting is relieving sometimes. Can be done usually the procedure of management by laparoscopy or single incision laparoscopic surgery or robotic surgery. This is the surgical approach. The transabdominal or retrogastric usually initiate excision of the tail of the pancreatic cyst if it is in the tail, and occasional if the head, usually pancreatic or duodenostomy or cystectomy or inoculation. Drainage transgastric pseudogastrocystostomy is very effective, and usually 90% of the pseudopancreatic or genostomy end with resolution in 91 to 97%. Pseudocystogastriduodenostomy can be complicated with duodenal fistula or anastomotic size bleeding.
Superficial and deep. We talk about the superficial venous system. We have two main veins: the great saphenous vein and the small saphenous vein, and there is tributaries of the great and short saphenous vein, and also there is perforators which connect the superficial system to the deep system, so the flow will be toward the heart and through the perforator from the superficial to the deep system. Next, please. So the physiology of the venous system is the vein return the blood to the heart. And what the pump the venous blood back to the heart is the venous pressure is about 25 mm mercury at the foot, and the pressure need about 80 mm mercury to return the blood to the heart. So we have two unique features for the vein. Accomplish this. Most important is one-way valve, venous valve, and the other way is the surrounding muscle, which is surrounding muscle is calf bump. The calf muscle bump is just like a heart. We have diastolic and systolic function that you see. Yes. Okay. Next. You see this. This is during diastolic relaxation of the calf. Also discoloration, hematosclerosis, and maybe also there's venous ulceration. Next. So about superficial system, we have three types of veins. We have the injectasia, confluence of dilated intradermal venules, and we have the reticular veins, which dilated loose subdermal ones, and there's varicose vein truncal or tributaries, dilated veins about 3 and more millimeter in size. Next. So this is the three types of varicose vein: the injectasia, reticular varicosity, and truncal or vein tributaries dilated. Next. So the incidence is increasing of varicose vein with the age, and the female is more common than male, and about 50% of population will be affected in their life. So it's high incidence. More. So what about the physiology? Usually associated with venous incompetence, maybe primary or secondary reflex. They will be maybe edema and vein wall dilatation, followed by inflammation, pigmentation, fibrin deposition, and vein ulceration. So etiology, reflex is 80%, venous obstruction 80 to 28%. This lead to edema, skin changes, and maybe lead to post-thrombotic syndrome, and the other cause is muscle bump dysfunction. What about the risk factor? Aging. Because of the aging, they may be wearing and cause the valve to malfunction, and 6 women is more than this may be due to hormonal changes, pregnancies, menopause, progesterone will lead to relaxation of venous wall. Genetics, obesity, increase the venous hypertension, and standing for a long period of time, and also prolonged mobile standing will be impair the venous return. Next, please. So there is a strong family component also. It's not well studied. Twin studies 75 identical and 52% non-identical. If the parents have varicose vein, 90 of his children they have varicose vein, and if the one parent was affected, 25% for the men and 61% for women they have varicose vein. So this is picture. I see this patient here yesterday. This is I operated on 3 months ago. This is the father. He have bilateral varicose vein, and this is the son. And he also have bilateral varicose vein with severe venous hypertension. You see this discoloration, and maybe after a year there will be low ulcer. Okay, I will do this tomorrow. Okay, next. So what is the symptom of varicose vein? Achy or heaviness feeling, burning, throbbing, and muscle cramping, swelling. Prolonged sitting or standing tend to intensity of the symptom. Pruritus, painful skin ulcer. So this is very important classification, CV classification, which is dependent on the clinical and etiological, anatomical, and pathophysiological.
work in brief in general plastic surgery department in المواساة as a work review. Next. First, we have to know from what came the word plastic. It came from plasticos, which is a Greek word that means to mold or to form. And really, plastic surgery has no specific definition. And Joe McCarthy, one of the pioneers in plastic surgery, he defined it as a problem-solving specialty. And plastic surgery, of course, has no specific organ to do surgery with this. So plastic surgery can work in craniofacial surgery, breast, abdomen, chest wall, and etc. Next. Generally, plastic surgery can be divided as a major classification as a reconstructive surgery and aesthetic procedures. So we have to talk about one of the common problems facing plastic surgery. It's a trauma. You see this is extensive trauma with soft tissue loss in the lower lip, nose, upper lip, and abrasions. And this is after doing surgery after a few months of treatment here in the المواساة hospital. This is another case of very unfortunate young lady with the total or subtotal abortion of the scalp, treated here in this hospital. We did as urgent surgery, we did a skin graft for her, and waiting for further scalp reconstruction for her. This is another case of trauma, head craniofacial trauma with head injury presented to me like this, with this scalp necrosis. And this is after debridement of all the necrotic tissue. And you see this is the problem of exposure of the cranium. So this is after we're doing a scalp flap for the baby. Next. This is another extensive trauma to the forehead and upper eyelid and some part of the nose. And this is after the primary suturing of the case. This is another extensive trauma, soft tissue on the bone. You see here leafwort fracture and spaced fracture mandible and lower lip injury. So the right side of the face drooping down. And this is after surgery and fixation of the bone and treating the soft tissue. Patient is very well. There's another kind of problems facing in plastic surgery. This is a depressed scar. Really, I think it's a wound, not suture. So you see the scar reaching to the bone. And this is after a clinic, a procedure by a fat injection, and you see the result. With no surgery, no wound. Next. There's another problem with a child with congenital ptosis of the right side. And ptosis means drooping of the upper eyelid downward. This is after surgery. It's a nice looking female. Another case of congenital ptosis of the right eye. Treated and see the symmetry. And by the way, the symmetry of a unilateral ptosis is very, very difficult to do and very, very difficult to achieve symmetry because the upper eyelid, 1 milli can be obvious and the patient will not accept the result. Okay? This is another case of congenital ptosis of the left upper eyelid. And this is post-operative result. And let's see don't think you see it very well. This is, let's see inside the surgery, this is the causative muscle, which is the levator palpebris superioris. This is the muscle you have to, or we have to identify the muscle to achieve success in surgery. This is another congenital deformity in craniofacial department. This is what is called a prominent ear or butt ear. This is a preoperative, you know, the prominence. And see, this is the postoperative. This is from the posterior view. This is a preoperative, and this is postoperative. Okay. Another type for breast surgery for female, this is augmentation. This is a slim patient, so she has no confidence with herself, and she cannot do anything in her life because she has no confidence. So you see, this is after augmentation of the first left breast, and this is after completion of the surgery. Okay. Another entity in breast surgery, this is a breast reconstruction. This is a bear, old bear in childhood, and the patient reaching adulthood without a breast. Because the breast but present, but no space to enlarge. This is after surgery, the first surgery, and this is after nipple reconstruction. Sorry for the pictures, not so good for publishing, because this is the present. This is a case of a male gynecomastia. We did it. This is a very advanced device for liposuction, labor-assisted liposuction. And thanks for by the way, for the directorate of this hospital for providing this device for doing such surgery. You see, this is a young male with this embarrassing deformity. So this is after surgery. There is no breast. Okay. This is a rare case. This is a unilateral gynecomastia. This is done by combined surgical and liposuction. And this is the post-operative. Okay. Another subject, hand surgery. This is a post-bearing contracture. This is a pre-operative. And this is after operation. We do a very good hand function. Okay. Another case of post-bearing contracture from the lateral or the medial side of the index and the thumb, and this is after surgery. Another complicated case, really. This is electrical bear. This is the exit point from the flexor groove, and after the debridement, you see all. I think the case of Dr. Hisham, he referred to me, if you remember. I did many surgeries to him, and with lost all the flexor groove. So we reconstruct first, doing abdominal flap.
Again, pain is one of the major causes for the patient coming back at the same day after surgery in America. So in America there are many reasons for the patient coming back to the hospital at the same day after performing surgery. One of them, or actually the major one, is pain, followed by some surgical or medical complaint that result that the patient come back to the hospital at the same day. But the major reason for this patient coming back to the hospital is the pain. So the post-operative pain is a global issue and it's usually inadequately managed. This leads to several complications which eventually lead to delayed post-operative recovery. So why there is inadequate pain relief? Why we are having suboptimal analgesia after operations? First of all, the patient himself has a low expectation of pain relief post-operatively. So he will not demand that much of analgesia. And pain is accepted as inevitable part of surgical operation. This is actually in the mind of our patient that, okay, he's going to do a surgery, he will going to suffer from pain. So the patient himself has a low expectation that will be pain-free after surgery. The second thing that local hospital regulation, as we know, may actually delay the administration of analgesic, or actually especially the opioid one, which are strong usually, the delay in administration at the optimum time. So how do we manage post-operative pain? I'm here presenting the guideline for managing post-operative pain 2016. It's actually unique a guideline because it's a joint guideline for managing post-operative pain by the American Pain Society, American Society of Regional Anesthesia, as well as American Society of Anesthesiologists. Each of these societies has a guideline by themselves, but in 2016 they made this uniform, or actually combined, joint guideline. So this is the guideline. One of its recommendations that we should use multimodal analgesia post-operatively, meaning that we should combine more than one analgesic to relieve the pain. Here a table, I'm just retyping it here again, of the most common type of surgeries and systemic pharmacological therapies and other local intra-articular or regional anesthesia that we can use to relieve post-operative pain. We can see here, regarding the type of surgery, in all types of surgeries, the paracetamol, IV paracetamol is included within the guideline. So we can combine actually paracetamol with most type of other analgesic that can be used. Non-steroidal as well is mentioned in approximately most type of surgeries apart from CABG and spinal fusion. So the guideline then recommend that we can combine acetaminophen, paracetamol IV with non-steroidals, and the visual aid scale measure for each patient. Here, the placebo, of course, there will be a significant difference between placebo and administration of paracetamol. But we can see here, the one in red, IV paracetamol 1 gram prior to skin closure, intraoperatively, or the orange one, 30 minutes prior to induction of anesthesia. So we can see the pain is much reduced compared when we administer paracetamol perioperatively. So that it will have to act, it will take approximately half an hour the onset of action, and peak will reach after 1 hour, and therefore usually it's recommended to give paracetamol IV perioperatively before induction of anesthesia at least half to 1 hour. Even so, if we administer paracetamol intraoperatively, it will also relieve the pain. There is a study, actually a meta-analysis, saying that prophylactic IV paracetamol reducing post-operative nausea and vomiting as well. This is actually a study published in Science Direct in Severe. We can see here, it's a review, systematic review of approximately 30 randomized controlled trial. The number of patients, approximately 2,000 patients, large number of patients. The conclusion of this study that IV paracetamol reduced nausea and vomiting when given prophylactically either before surgery or before arrival to post-anesthesia care unit, but not when given after the onset of pain. Because usually it is believed that one of the mechanisms to induce the nausea and vomiting for the patient is through the pain. So if we can deprive the patient from this pain from occurring, we will reach a degree of nausea and vomiting which is significantly different than other. So the idea that, okay, it will act as analgesia, of course, pre-operatively, intraoperatively, or post-operatively. But if we want this, say, add-on effect, we should give paracetamol before the onset of pain, which is usually prior to induction of anesthesia, or actually pre-operatively by 30 to 1 hour. This is actually the result of meta-analysis, which is significantly different for nausea and also for vomiting. So finally, what's special about paraconica? What Asino have to offer about paracetamol IV? The paracetamol, as we know it, as a tablet, was introduced in the market approximately in the 50s, while IV paracetamol approved in European Union in 2002 and only in 2010 get FDA approval. So it's recently introduced to our market. So there is a gap approximately 50 years between manufacturing of an oral form of paracetamol and a liquid IV formulation of paracetamol. This is actually because formulation of paracetamol as a liquid has many challenges. One of them is that paracetamol undergo hydrolysis in aqueous medium at high and low pH to give us 4-aminophenol, which is a product that is nephrotoxic. So Paraconica is synthesized within an optimum pH between 5 to 6 to ensure that there is no hydrolysis of paracetamol. Again, paracetamol is sensitive to oxidation process by atmospheric oxygen to yield a hepatotoxic compound, now PQI.
أو في الليلة مال العملية تسأل واحد سوى عملية البصرة راح يجي لك اشتكي بالليل. وإذا تسأل عن علم الولادة 3 خوات قاعدات. أكو واحد ما خاف من العملية كذا خاف. شكرا جزيلا. Patient control analgesia. احنا أهم شيء الألم ما بعد العملية يسيطر عليه. المريض يكون satisfied، الستاف يكون satisfied. ما معنى patient control analgesia؟ ساعدني تفضلك؟ لأن أنا شوي أتحرك ما أقدر. البيشنت كنترول انستيزيا اخوان شوي سمعوا في مصطلحات باكر الاهل في المستشفى شوي بعض العبارات مفيده. Using programmable syringe pump to allow patients to self-administer their own analgesia. يعني المريض يساهم بعلاج الألم مالته. ماشين نستخدمها ماكينة. الفكرة بدأت من 1968 مو جديدة. وتعلمت بالثمانينات. احنا هسه قاعدين نتعلم. يعني كده مختلفين ثم تفهموا. Next please. هي ماشين ماكينة. اما الالكتريكال ماشين الكترونيك سعرها تقريبا $1200 إلى $3500. هذا بالنسبة لإدارة المستشفى الدكتور إبراهيم قاعد حبيبي موضوع يعني حكيت فيها إدارة الصحة قالوا خاف من كبير قبل 5 سنوات كان صار حادثة خطر وتوفى من يسوي حوادث يعني الموضوع برغم بساطته فيه يسوي حوادث إغراء يعني هاي تكنولوجيا أو عندك disposable pump هاي disposable بلاستيك ما يراد لا كهرباء لا الكتريسيتي خفيفة الوزن سعرها تقريبا من $30 إلى $80 ولا في الصينيات حتى $5 سعر بس يسوي مشابه. طبعا استخدامها للإما انترافينوس انستيزيا بالوليد أو للبيديورا جماعة الولادة دكتور عبد الخالق قاعد إن شاء الله تفيدك هذا الشيء ديسبوزبل لا نجيبه أو نخليها برينيورال يعني المريض يسوي عملية بيده خليها بريكر الأقصاص تطلع أو مريض يسوي عملية بالركبة شوف الناس ما تركب عندك في مرض الناس وتفيد المريض حتى من يطلع من وراء العملية يعني تلاحظ يطلع المريض وراء العملية قد ما تنتهي مسكنات فوق بسيطة. ما هي فوائد PCA Patient Control Analgesia؟ Patient إذا بدأ أنت تساهم بعلاج الألم ما تفرق معي أكثر يمكن بالعمليات أكثر. رابيد ريسبونس ما اكو داعي ما راح ينتظر الممرض على ما يفرغ الجيله يعني عمليه ثاني بسرعه هو يدوس الدم وتبي الشغله. ريديوس بيشنت انكزايتي عشان تلقى هذا عنده الم ورا العمليه وتعال تبسم فوق اوبرا انا ساهم اروح الليل ورا العمليه جبت لا باذن برجوك ما سوي شيء. فاذا هنا المريض ما راح مجرد هو الدرجه ينطلق بالوريد او بالبيدورس فيه مجرد يدوس المريض ضد المواد هذا بس يقولون fewer complications حوادث قليلة بهاي الأجهزة حسب ما يقدرون الخبراء excellent analgesia increased satisfaction قناعة المرضى قناعة الستاف قناعة الفاميلي بالإدارة إدارة الألم ويقلل اللود على الستاف على الممرضين قدر الإمكان في البوست اوبريتيف بيريود. next please. أكثر ما يخوف الأطباء في العراق هو المورفين. حقيقة ما خوف المورفين ما شاء الله. المورفين المفروض يتوفر بس احنا طبعا عندنا مشاكل الأمم المتحدة بالمورفين ما تقدر بعنا سبب ريجستريشن. بالنسبة لوزارة الصحة الدكتور ما جاي يتقدر وبصراحة الدولة أي دولة ما تعطي مورفين لمرضى مقصرة. ومع الأسف إسرائيل بدأت في شمة بيده هذا الحكي قبل 20 سنة احنا متابعين يقول العرب كلهم يصرفوا مورفين اقل من اسرائيل بالنسبه للمواطنين مالهم الصرف. فاذا اكو تقصير بهذا المجال في الدول العربيه ما احدد. هسه الحكي هذا جوكم فوق هكذا محكايه يتم الجبل. المشين فيها ثلاث مصطلحات خصوصا بالكهربائي. اكو مصطلح البلك دوز، اكو لوك اوت تايم، هاي وحده راح تجاري. اكو ديوريشن اوف ذا دوز، اكو باك جراوند انفيوجن. هاي المصطلحات يفهمها الطبيب والممرض الصيدله لان هي الاساس تعتمد عليه PCA كنترول. بس البلس دوز الذي يمكن يحسبها لنا يدوس الدماء عينه باللي الدماء تدمر بطن يدوسها يحس بالالم الجهاز يطلق يترك. بلس دوز هي سمول دوز يعني تقريبا 1 cc. هنا طبعا المخرج مالت العمليه كلها هم الجماعه اللي يحضرون الدركس بعبيد المشين يضبط الكونستريشن. اكو مريض ما يتحمل ساعه يفرق. اكو عمليات مؤلمه جدا. فهنا الدور هم جماعه المختصين بالالم يضبطون الجرعه مالت البلس دوز. الجهاز